Hi everyone, welcome to PharmaGrid. So today we are going to discuss about gout, mainly the pathophysiology and the treatment options for the gout. Okay, so as you all know, gout is a metabolic disorder characterized by high levels of uric acid in the blood. This high levels of uric acid in the blood is known as hyperuricemia. So in a summary, we can say that gout is a metabolic disorder characterized by hyperuricemia. This hyperuricemia can lead to deposition of sodium urate crystals in the tissues, especially in the joints and the kidney. That is, this gout mainly affects the joints as well as the kidney. The deposition of urate crystals initiates an inflammatory process involving the infiltration of granulocytes, granulocytes in the sense mainly the neutrophils, that phagocytize the urate crystals. So the acute flares of gout usually present as, or the symptoms of acute gout mainly involves pain, swelling, tenderness and redness in the affected joints. For example, big toe, knees, ankles, wrists or elbows. The cause of hyperuricemia in gout is an imbalance between the overproduction of uric acid, overproduction or increased synthesis of uric acid, or the inability of the uric acid to excrete renally. Most therapeutic strategies or treatment options for gout involve lowering the uric acid level below the saturation point. Below the saturation point in the sense below 6 mg per deciliter, thus preventing the deposition of urate crystals. This can be accomplished by interfering with uric acid synthesis or increasing uric acid excretion. So here you can see one diagram. So from this purines, so the main content or main constituents of this DNA and RNA is purines. So from this purines, they get converted to hypoxanthine, and from hypoxanthine to xanthine and xanthine to uric acid. So these two steps, or the uric acid production or the uric acid synthesis, is mainly catalyzed by the enzyme xanthine oxidase. And here you can see these two drugs, that is allopurinol and febuxostat. They are xanthine oxidase inhibitors, mainly used in the treatment of gout by reducing the uric acid production. Okay, so this is how uric acid is produced from purines, hypoxanthine, and from hypoxanthine to xanthine, and from xanthine to uric acid by the enzyme xanthine oxidase. So once the uric acid is produced, here you can see the phagocytosis of uric acid crystals by neutrophils. Okay, so here you can see the phagocytosis of uric acid by the neutrophils, mainly the granulocytes. And inside you can see the lysosomes. So the lysosomes mainly contains the hydrolytic enzymes. Okay, once after the phagocytosis, what will happen? There will be the release of leukotrienes and other mediators of inflammation. Okay, so once after the phagocytosis, the release of leukotrienes as well as other mediators of inflammation will be released. And this is the site where the colchicine acts. Okay, this is the site where the colchicine acts. So after the release of this inflammatory mediators, what will happen? There will be the rupture of lysosomes. Okay, here we have seen the lysosomes which contains hydrolytic enzymes. So once the lysosomes got ruptured, followed by the death of phagocyte, and there will be release of the hydrolytic enzymes. All together results in acute inflammation. Okay, so this is how the gout will occur, or this is how the pathophysiology of gout will happen. Now we'll see the treatment of acute gout. So the acute gout attacks can result from number of conditions including excessive alcohol consumption, a diet rich in purines and a kidney disease. So as a treatment of acute gout, we are mainly using NSAIDs, that is non-steroidal anti-inflammatory drugs. Corticosteroids and colchicine are effective agents for the management of acute gouty arthritis. Intra-articular administration. Intra-articular administration means directly into the joints. Okay, so the intra-articular administration of corticosteroids when only one or two joints are affected is also appropriate in the acute setting, or systemic corticosteroids for more widespread joint involvement. So the patients are candidates for prophylactic urate lowering therapy. Prophylactic in the sense preventive. Okay, so in order to prevent further attacks or prevent the gout, the patients are candidates for prophylactic urate lowering therapy if they have more than 2 attacks per year, or they have chronic kidney disease, kidney stones or tophi. What do you mean by tophi? Tophi means deposit of urate crystals in the joints, bones, cartilage or other body structures. Okay, so among these NSAIDs, indomethacin is considered the classic NSAID of choice, although all NSAIDs are likely to be effective in decreasing pain and inflammation. So in the previous slide, we have seen the treatment options for acute gout. Now we will see the treatment of chronic gout. Urate lowering therapy for chronic gout aims to reduce the frequency of attacks and the complications of gout. So the main treatment strategies include two main categories. The first one is xanthine oxidase inhibitors and the second one is uricose uric drugs. So xanthine oxidase inhibitors reduce the synthesis of uric acid. Examples include allopurinol, febuxostat, and the xanthine oxidase inhibitors are considered as the first line urate lowering agents. And the next category is uricose uric drugs. They are mainly aimed to increase the uric acid excretion. Example include probenecid. These uricose uric agents may be used in patients who are intolerant to xanthine oxidase inhibitors or fail to achieve adequate response with those agents. Then initiation of urate lowering therapy can precipitate an acute gout attack due to rapid changes in serum urate concentrations. So medications for the prevention of an acute gout attack, as we have already learned, that is low dose colchicine, NSAIDs or corticosteroids, should be initiated with urate lowering therapy and continued for at least 6 months. Now we will study each drug separately. So the first one is colchicine. Colchicine is a plant alkaloid used for the treatment of acute gouty attacks. It is neither a uricose uric nor an analgesic agent, although it relieves pain in the acute attacks of gout. So coming to the mechanism of action, which is very important, especially in case of pharmacy exams. So this colchicine binds to tubulin. What is this tubulin? It is a microtubular protein. So the colchicine binds to tubulin, causing its depolymerization. This disrupts cellular functions such as the mobility of neutrophils, thus decreasing their migration into the inflamed joint. As we have already seen in the pathophysiology, there will be phagocytosis of these urate crystals by the neutrophils. So what this colchicine will do? This colchicine binds to the tubulin, causing its depolymerization, and thereby it disrupts or damages certain cellular functions such as the mobility or movement of neutrophils or decrease their migration into the inflamed joint. And also one more mechanism is there. Colchicine blocks cell division by binding to mitotic spindles. Coming to the therapeutic uses, the anti-inflammatory activity of colchicine is specific for gout, usually alleviating or decreasing the pain of acute gout within 12 hours. Then this drug must be administered within 36 hours of onset of attack to be effective. NSAIDs have largely replaced colchicine in the treatment of acute gouty attacks for safety reasons. Colchicine is also used as a prophylactic agent to prevent acute attacks of gout in patients initiating urate lowering therapy. Coming to the pharmacokinetics of colchicine, colchicine is administered orally and it is rapidly absorbed from the gastrointestinal tract and metabolized by the CYP3A4 isoenzyme. It undergoes enterohepatic recirculation and exhibits high interpatient variability in the elimination half-life. A portion of the drug is excreted unchanged in the urine. Then regarding the adverse effects, colchicine may cause nausea, vomiting, abdominal pain and diarrhea. The chronic administration of colchicine may lead to myopathy, neutropenia, aplastic anemia and alopecia. And this drug should not be used in pregnancy and should be used with caution in patients with hepatic, renal or cardiovascular disease. Adequate drug holiday must be given between dosages to avoid cumulative toxicity. And as I have already mentioned, this colchicine is metabolized by CYP3A4 isoenzyme. So dosage adjustments are required in patients taking CYP3A4 inhibitors, for example, clarithromycin and itraconazole, or P-glycoprotein inhibitors, for example, amiodarone and verapamil, and those with severe renal impairment. Next drug is allopurinol, which is a xanthine oxidase inhibitor and also it is a purine analog. Then what is the mechanism of action? It reduces the production of uric acid by competitively inhibiting the last two steps in the uric acid biosynthesis. What are the last two steps? From purines get converted to hypoxanthine and hypoxanthine to xanthine and xanthine to uric acid. Okay, so these two steps are initiated or catalyzed by the enzyme xanthine oxidase. What this allopurinol will do? This allopurinol competitively inhibiting the last two steps in uric acid biosynthesis that are catalyzed by xanthine oxidase. Then therapeutic uses. This allopurinol is mainly used for the treatment of gout and hyperuricemia secondary to other conditions such as that associated with a certain malignancies. Malignancies means in such conditions there will be overproduction or there will be presence of large amounts of purines. Okay, there will be presence of large amounts of purines particularly after chemotherapy or in renal disease. Then adverse effects. Allopurinol is well tolerated by most patients. Then hypersensitivity reactions, especially skin rashes, are the most common adverse reactions. The risk is increased in those with reduced renal function, Because acute attacks of gout may occur more frequently during the first several months of therapy, colchicine, NSAIDs or corticosteroids can be administered concurrently. Pharmacokinetics. Allopurinol is completely absorbed after oral administration. The primary metabolite of allopurinol is alloxanthine, also known as oxypurinol, which is also a xanthine oxidase inhibitor. It has got a half-life of about 15 to 18 hours. Okay, so thus effective inhibition of xanthine oxidase can be maintained with once daily dosing because of the long half-life. The drug and its active metabolite are excreted in urine. So the active metabolite of allopurinol is alloxanthine or oxypurinol. So dose adjustment is needed if the estimated glomerular filtration rate is less than 30 ml per minute per 1.73 meter square. Okay, so the next drug is febuxostat. It is also an oral xanthine oxidase inhibitor structurally unrelated to allopurinol. This drug is rapidly absorbed after oral administration with the time to reach peak concentration, that is Tmax, being of approximately 1 hour. And this drug is highly bound to albumin in the blood, approximately 99%. Then low to medium apparent volume of distribution of approximately 0.7 liter per kilogram. Then febuxostat is indicated for the long-term management of hyperuricemia in patients with gout at a dose of 10 to 120 mg once daily. Adverse effect profile is similar to allopurinol, although the risk for rash and hypersensitive reactions may be reduced. And one more advantage is that febuxostat does not have the same degree of renal elimination as allopurinol, so it requires less adjustment in dose with reduced renal function. Adverse effects include abnormal liver function test, then abdominal pain, diarrhea, headache, joint-related signs and symptoms, and musculoskeletal and connective tissue signs and symptoms. Febuxostat should be used with caution in patients with a history of heart disease or stroke. Now we'll see about probenecid, which is an oral uricose uric drug. It is also a weak organic acid that promotes renal clearance of uric acid by inhibiting the urate anion exchanger in the proximal tubule. So probenecid is a weak organic acid. Then its main aim or its mechanism of action is to promote the renal clearance of uric acid. How? By inhibiting the urate anion exchanger in the proximal tubule. At therapeutic doses, it blocks the proximal tubular reabsorption of uric acid. And this drug should be avoided if the creatinine clearance is less than 50 ml per minute. Adverse effects include nausea, vomiting, and dermatologic reactions, and rarely anemia or anaphylactic reactions. Dose of probenecid is 0.25 to 0.5 gram twice daily. However, intermittent colchicine therapy is indicated to avoid acute precipitation of gout. Okay, so the next one is pegloticase. This pegloticase is a recombinant form of the enzyme urate oxidase or uricase. Okay, so this pegloticase is a recombinant form, and how this drug will act? This pegloticase acts by converting uric acid to allantoin. Okay, what is this allantoin? It is a water-soluble non-toxic metabolite that is excreted primarily by the kidneys. So this pegloticase is a recombinant form of the enzyme urate oxidase or uricase. This acts by converting uric acid to allantoin. Allantoin is a water-soluble non-toxic metabolite that is readily excreted by the kidneys. And this drug is mainly indicated for patients with gout who fail treatment with standard therapies such as xanthine oxidase inhibitors, administered as an IV infusion every 2 weeks. So this infusion-related reactions and anaphylaxis may occur with pegloticase, and patients should be pre-medicated with antihistamines and corticosteroids. Okay, so we have completed the pathophysiology as well as the treatment options for gout. If you have any doubts, you can post your valuable comments or you can share your doubts in the comment section. Thank you everyone for watching this video. Please like, share and subscribe. Thank you everyone. Have a good day.